Good morning. My name is Thiago Reis, and today we'll talk about electrolyte management in CRT. I'd like to thank Novo Biomedical for this kind of invitation and for organizing this session. These are my conflict of interests. And today we'll talk about efficacy and safety of regional citrate anticoagulation, ionized calcium in CRT, both systemic and post-filter ionized calcium, and the electrolyte imbalances that frequently occur during CRT, usually hypophosphatemia, hypokalemia, and hypomagnesemia. Also about magnesium, ionized, and total. We will stress the difference between these two forms, hypomagnesemia and clinical outcomes, and point of care analyzer. So citrate chelates cations, and usually in the body we have these forms of citrate. So the solution is sodium citrate, then citrates gets bind to calcium, and that hinders the coagulation cascade, but also gets linked and chelates ionized magnesium. This is the most important trial so far, comparing citrate regional anticoagulation versus heparin. In this trial, they utilized 0.5% sodium, trisodium citrate, and the main outcomes were mortality. There was no difference in mortality, but also median filter lifespan. So there was a difference of 15 hours between the citrate group and heparin group. This is demonstrated here. In the x-axis, we have timing hours since the start of the therapy, and here filter lifespan. We can see that with citrate, we have a better filter patency, 47 hours of filter lifespan in citrate group versus 26. And also importantly, less bleeding in the citrate group. So 5.1 versus 16.9% of episodes of bleeding. Importantly, we need to highlight that within 30 minutes of citrate discontinuation, citrate and ionized calcium return to normal, to baseline values. So it's a drug with a short half-life. Concerning the accumulation of citrate, so in this study, including more than 1,000 patients, it was demonstrated that patients with hyperlactatemia and sustained hyperlactatemia had a risk of 6% of citrate accumulation, whereas patients with normal lactate or hyperlactatemia but not sustained, they had a less than 3% risk of citrate accumulation. Importantly, citrate in systemic in the body does not increase the risk of bleeding because it only hinders the coagulation cascade when it's below 0.4 mLs per liter, the concentration of ionized calcium. And this is not compatible to life. So we reach those values within the filter, but not in human blood. Therefore, citrate does not increases the risk for bleeding, and it can safely be used in patients with active bleeding. And this is the representation, the blueprint of a CRT circuit. So briefly, the citrate gets here in blood. Then we have a blood pump. We measure in the patient before citrate gets into the circuit and mix it with blood, ionized calcium. Blood passes through the filter, and we measure here post-filter ionized calcium, and then we replace calcium before this returns to the patient. We measure ionized calcium and electrolytes every 6 hours, usually 4 a.m., 10 a.m., 4 p.m., and then 10 p.m. with this device. And here's the blueprint of the CRT circuit. So blood, again, from left to right, the blood comes from the patient, gets citrate. We usually start with the concentration of 3 mLs per liter of citrate. using 0.5% citrate. Blood passes through the blood pump, then dialyzer. Here's the dialysate solution. Usually this flow 1200 miles per hour. The blood keeps going, passes through the warmer, bubble trap, gets the replacement of calcium, and then returns to the patient. It's important to stress that this solution that accounts for half of the dialysis dose this patient is receiving in the form of pre-filter convection does not have magnesium, does not have phosphate, does not have potassium. So the patient is prone to develop hypophosphatemia, hypomagnesemia, and hypokalemia because 50% of the dialysis dose does not have all those electrolytes. To calculate or estimate the concentration of a given solute that the patient on CRT will be exposed to during the treatment, we have this weighted arithmetic mean, which means we have the final concentration will be the sum of the concentration of, for example, in this case, potassium in the citrate times citrate flow, and then the concentration of citrate in the dialysate and potassium in the dialysate times dialysate flow, and the concentration in the replacement solution times replacement flow divided by all those flows together. So in this specific case, this gives us that the patient will be exposed to a potassium concentration of 2.5 millimoles per liter, and this patient will certainly develop hypokalemia, which is harmful, right? Now, concerning magnesium, so biologically active magnesium is in the ionized form, which accounts for 2/3 of total magnesium, and 1/3 refers to magnesium bound to proteins or with other in salt forms. And when we carry out CRT with regional citrate anticoagulation, at least 30% of that ionized magnesium now is complexed with citrate. So we have less availability of ionized magnesium during citrate anticoagulation. And this was explored in the study performed in Czech Republic. So here again, just as a reminder of the CRT circuit, the blood comes from left to right. And those researchers measured pre-filter ionized calcium and pre-filter ionized magnesium, also post-filter ionized calcium and ionized magnesium. And they proved that post-filter ionized calcium correlates with post-filter ionized magnesium. Remember, both cations are divalent cations. So here in the y-axis, we have the concentration of post-filter ionized calcium. Usually the adequate range to block the coagulation cascade would be from below 0.4, and we work in the range of 0.2 to 0.4, and it was proved that there is a linear correlation between post-filter ionized calcium and then here ionized magnesium. The same for the percentage reduction of calcium, ionized calcium, and also the percentage reduction of ionized magnesium. So we see here that there is a reduction of, for example, in this point here of 66% of ionized calcium, and similarly around 68% reduction in post-filter ionized magnesium. Again, to calculate and estimate the concentration of magnesium that the patient will be exposed to during the treatment, and now I'm referring to total magnesium, is the concentration of magnesium in each of the solutions. So in the citrate solution, in the dialysate solution, and also in the post-filter replacement solution. And as we don't have magnesium in this bag, and this bag accounts for almost 50% of the final dialysis dose, the estimated concentration of total magnesium will be only 0.42. Remember, the normal range is from 0.75 to 1. So this patient is prone and certainly will develop hypomagnesemia. This study in the Netherlands with 92 individuals compared how is the ionized magnesium correlation with total magnesium in patients, in severely ill patients on the ICU, but not on CRT, versus patients undergoing CRT therapy with regional citrate anticoagulation. So the circles represent patients not on CRT, and we can see there is a linear correlation. This dashed area, this darker area, represent the normal concentration of total magnesium, 0.75 to 1. And here is the ionized magnesium concentration in the normal range for it is from 0.5 to 0.75. And here we see that there is a linear correlation, which means that if you have a total concentration of magnesium, which is in the normal range, you will have also a normal concentration of ionized magnesium, which is important and demonstrate that in those patients is not necessarily important to measure ionized magnesium, because if your total magnesium is fine, then your ionized magnesium will also be fine, probably, likely. Nonetheless, the squares represent patients on CRT with citrate anticoagulation. And we can see here that in those measurements, patients had a normal total magnesium. However, those patients here, they had low ionized magnesium. So in those patients, we had the false impression that their magnesium concentration was normal, but actually they had a reduction in the bioavailable form of magnesium, which is the ionized one. So there is a linear correlation of total magnesium and ionized magnesium in critically ill patients. Nonetheless, this is not true for patients undergoing CRT with regional citrate anticoagulation. This was recently published in Thailand. So the aim of this study was to explore citrate kinetics in patients with acute liver failure or acute on chronic liver failure. This picture here in the x-axis, in the horizontal axis, we have the time since commencement of the therapy of CRT with citrate. And in the vertical axis, we have the change in ionized magnesium. The study included 7 patients with acute liver failure and 7 patients with acute on chronic liver failure. Well, from the baseline, it was demonstrated that patients with acute and chronic liver failure had reduced concentration of ionized magnesium around 0.5. So after the treatment starts, there is an expected reduction in the concentrations of ionized magnesium, because we've seen that there is this link between ionized calcium and magnesium with citrate. The therapy ran with citrate for 2 hours, and then the infusion was stopped and the patient continued CRT, but not anymore with citrate regional anticoagulation, and we can see that in 60 minutes to 2 hours, there was a return to the baseline concentration of ionized magnesium. Remember, in the first slides, I've told you that it takes 30 minutes for citrate to return to baseline. However, that is in patients without liver impairment. Those patients here, of course, they had liver impairment, so it takes a little while until the concentration of citrate and other ions like magnesium and calcium to return to baseline. This study was conducted in Brazil with 232 individuals. It was an observational study. And when patients were admitted to the ICU, they get total magnesium measurement. And on this cohort, 118 patients developed AKI, any stage of AKI, and 114, no, they had no AKI, normal kidney function. Well, in the group of patients that developed AKI, 47% of them had hypomagnesemia, whereas in the group that had no AKI, 62% had hypomagnesemia, and there was no difference in a statistically meaningful difference between those two groups. So, okay, this is an observation analysis. It was interesting that those patients, now we are only in the universe of patients with AKI. So those that recovered from AKI, 31% of them had hypomagnesemia. However, the patients that had and presented persistent AKI, 70% of them had hypomagnesemia. So maybe hypomagnesemia is a sign or prone patients to have a more prolonged state of acute kidney injury. Another trial, this one in Belgium, with 446 patients, critically ill in the ICU. It was also an observational trial, and they measure this time ionized magnesium. The other study was with total magnesium, and this one with ionized magnesium. And in this cohort of patients, 18% had hypomagnesemia, 68% normal, and 14% hypermagnesemia. Well, in this cohort, 23 patients that had either hyper or normal magnesemia developed de novo. Okay, so they developed ionized hypomagnesemia. And those patients had a higher Apache 2 score, a higher SOFA score, were more prone to have septic shock, to have longer ICU stays, and a higher mortality. Importantly, those two trials were observational trials. So we know that correlation is not causation. So should this cat be blamed for this blunt column? So no interventions in those trials were carried out, and we need to be cautious with our conclusions that, for example, hypomagnesemia will increase mortality, and if we correct it, then we would have better outcomes. This needs to be further explored in clinical trials. Well, the point-of-care analyzer allows the identification of ionized hypomagnesemia because this data is not usually available. Also, with the point of care, there are few time periods of CRT ionized calciums in the circuit above 0.35. So with that, we will have a presumably a prolonged circuit patency. At the same time, we will have fewer time periods of CRT circuit ionized calcium below 0.25, because when we do normal tests, it takes at least 2 hours to have back from the lab your concentrations of ionized calcium. And here it's only like 30 seconds. So if you have less period of time with citrate below 0.25, you are consuming less citrate because you don't need to have a concentration below 0.25 in order to block the coagulation cascade. And with the point of care analyzer, there is a timely correction of magnesium, calcium, potassium, sodium, and bicarb. With this, I thank you, and let's move forward. Thank you.